our YouTube channel. So just moving on. So yeah, we host a couple of free webinars. You can have a look at our YouTube channel. I guess the most important thing I'm getting out of this is just feedback at the end, and also I just love teaching. But if you want to check out our YouTube channel or contact us if you have any other queries, feel free to do so. So an introduction, so I'm not affiliated with the MRCP team at all. I'm not an examiner. This is just information from my experience and also from the MRCP website. I did the diet just before the exam changed, but I have looked up how it's changed for this new diet. So hopefully it's basically almost the same, just a few changes, which I think are more positive than anything. Yeah, so I have MRCP diploma now, and this is going to be a series of sessions because I do have 151 slides here, and I don't think we're going to get through all of them. So I'm planning on having the next session on the 7th of October, and you can book via the same Eventbrite link, which you originally booked through. So I think the main thing is to practice as much as you can. Practice on normal people, practice on the wards. You just need to get your technique really slick, and it just needs to come naturally. The main thing is that you don't want to be thinking about what's next in my examination. Your examination should just become muscle memory in a way, so that you're actually just thinking about pathology in the exam and thinking about putting things together. Also, I would recommend timing yourself, maybe getting a stopwatch, and just seeing how you do. And just find a systematic approach that works for you. I mean, everyone has different approaches. There's no right or wrong. It's just about getting through all the components of the examination, and doing it in a thorough but also composed, calm manner. Yeah. So a few general principles. So I'm sure many of you have heard of WIPO QQ. So it just stands for washing your hands. So just use the alcohol gel at the end of the bed, introducing yourself to the patient, asking for permission. You don't really have to say, may I please examine you? You can just say, I've been asked to examine you today. Is that all right? Ensure, I can't emphasize this enough, ensure the patient is exposed adequately. If they're wearing a gown or shirt in the exam, ensure that you can see the area you're examining completely. Don't examine over clothing because you will fail. And also, if the patient's not in a position you know, in the ideal position for examination, for example, in the abdominal station, if they're sitting upright, then make sure you get them into the correct position before you start examining them, because you will lose marks if that's not done. Also, it's a question of patient safety. If you're examining the abdomen when they're sitting up, it's not really safe. It's also could be quite painful to the patient. So you could lose marks on those two components. And then the QQ and WIPO QQ stands for two questions. Are you comfortable? Are you in any pain? And you shouldn't really be asking the patient any other questions in the examination stations themselves. So then we move on to just general inspection, palpation, percussion, and auscultation. And then after you've done all of this, you'll literally have 5 seconds to put it all together in your head. So this is why it's so important to, as you're going through, to put the science together and already have a diagnosis in your head, even from when you've just walked into the station and look at the patient. A lot of the times you can get the diagnosis just by what's around the bedside. So by the time you've done your auscultation, you're already thinking, okay, this is my diagnosis. These are the tests I want to do. This is going to be my management plan. Just muting a few people. So how I go about discussing investigations, I always start with bedside investigations, and bedside investigations would include your ECG or making sure that you have a set of observations, urine dipstick, and then I'd move on to blood tests, imaging, and then you can move on to other investigations depending on the system. So, for example, sputum MCNS or anesthetic tap. And yeah, so for those who've just joined, I've just basically said that you really need to have a stepwise approach. Make sure that your examination is based on muscle memory, so you can do the examination in your sleep. If someone wakes you up at 2 a.m., you can quickly do your abdominal examination or quickly do the neurological examination, and it's not something you're thinking about, what's the next step? Because then you're wasting time thinking about what you're going to do instead of assimilating all the signs that you have at the bedside. And also when you're examining, think about, if you have a patient with a metallic valve, think about complications while you're examining, because then you will get the top mark if you also explain associated complications you've looked for and things you want to exclude. I think most people score really well in the investigations and management side of things. So the main focus would be to, nailing the diagnosis and the differential diagnosis. Because I'm pretty sure we're all quite safe with investigations and management. The other thing is if you do get the diagnosis incorrect, some examiners might mark you down on the investigations and management if they don't give you a heads up on the correct diagnosis. So if in your exam you hear them saying, say this isn't COPD and it's a pneumonectomy, then you should take the hint that actually the diagnosis is probably wrong and it's a pneumonectomy, and you should answer questions along the pneumonectomy line to try and get the marks for management and investigations. So with the new PACES carousel, what's been taken out? So station 2, which was previously the history station, was very artificial, having done it myself. And you weren't allowed to examine the patient. So this is something that wouldn't happen in clinical practice. So they've removed it, thankfully. Station 4 is no longer 20 minutes. So station 4 used to be the ethics station. You'll now have, ethics/communication station, you will now have 2 10-minute communication stations instead of one long 20-minute station. And in your communication station, you won't be asked any questions. And then with station 5, they are now 2 station 5s. Well, they previously were 2 station 5s, but you get more time. And it's really important to pass station 5 because this is where you're basically being assessed on all the components of the examination, history taking, patient well-being, etc. We'll go through an example of the mark sheet in a bit. So we've talked about this. So what's new is the 2 10-minute communication sessions, and there's no Q&A. So the examiners would literally just assess you from the observation. And then the consultations. So the good news is that you'll get 20 minutes instead of, I think we had 14 minutes. And so you'll have 15 minutes to take a structured history, examine the patient, explain the likely diagnosis and management plan, as well as, importantly, addressing their concerns. And then 5 minutes for basically a viva with the examiners. So this is just looking at how the carousel's changed in 2023. And I think you guys will be basically the guinea pigs. But I think it's all very positive changes, and I think it's going to make the exam less stressful. So you can start at any of the 5 stations, and the key is that you have a 5-minute interval between the stations. So if, for example, I think I started at station 5, so I went straight into it, you'll get the scenario. You sit down, read, you get a piece of paper and a pencil, and you'll be able to jot down any points you want before you go into the station. So you could write down your key questions you want to ask on systemic inquiry or differential diagnoses on your piece of paper. And then you go in, see the patient, spend 15 minutes with them. So history exam, addressing their concerns, explaining management, and then Viva for 5 minutes. Then you move to, for example, so I went from station 5 to station 1, and then you'll have a 10-minute communications session where you'll just be asking, you just be asked to explain maybe a DNA CPR decision, or if someone has had a stroke, for example, and they've been requiring quite a lot of rehabilitation, you might need to explain, what's been happening in hospital or what therapy they've been receiving and the long-term management plan. And then you'll move on to the respiratory exam, which is just a 10-minute focused exam. You'll basically, for this, I think you have 6 minutes to examine and 4 minutes for the Viva. So in 6 minutes, you have to have done all the components of the respiratory exam, then Viva for 4 minutes, and then 5-minute interval, and then you move on to the next stations. So stations 2 and 5 are basically just the consultation stations. And then station 3 is a bit hectic because it's cardiovascular and neurology. And straight after you've done the CVS exam, you move straight onto the neurology patient. So don't waste any time. Thank the examiners, move on to the next station, which is neurology. And usually it's the same 2 examiners examining you in station 3. So one will be the lead for the CVS exam, and one will be asking questions and be the lead, and one will take a step back, and then they'll rotate for the neurology exam. I guess it's kind of nice so that they both get a feel of marking you as the lead examiner and asking questions. Yeah. And then station 4, so another communication station, abdominal station, and then you're done. So the marking sheet, this is actually the brand new marking sheet. It's very similar to what we had. So you are assessed to, this is an example of the station 5 or brief clinical consultation station. There are 7 domains of clinical skills you get marked for, and you should really focus all of your time on practicing station 5 because it is almost a third or something of your marks, and it assesses every skill. So you can basically see, you can either just get satisfactory, borderline, or unsatisfactory, and then the examiners will elaborate with a comment. I think for maintaining patient welfare, everyone should be scoring, full marks for that domain. It's just ensuring that you've asked the patient before you're going to do something, for example, checking collapsing pulse, ensuring you've asked that they don't have any shoulder pain, or before you're going to examine the abdomen, making sure they're not in any pain, and just saying, if you're in any pain, let me know and I'll stop. Basically things you just do on a normal everyday basis. I think on the MRCP website, there's a PDF, and this is where I found all the mark sheets. There's a PDF with all the mark sheets if you wanted to have a look at that. So now we'll move on to just going to mute one of the people. Okay. Move on to stations 1 and 4. So the communication stations. So 10 minutes each, you have the entire 10 minutes. What's nice is they normally give you a 1-minute warning. So at 9 minutes, the examiner might say you have 1 minute remaining. And that's a good indication of, okay, now I need to summarize and wrap up whatever you've been discussing. So for the clinical communication station, you'll just be marked on the 4 domains of the communication itself: managing patient concerns, your clinical judgment, and maintaining the patient welfare. So in these stations, you need to really be thinking about asking, what their main concern is. Have I actually addressed your concern? Is there anything else they'd need? And remember that you can offer them
anything. It's kind of an unrealistic world, the PACES world. You could literally offer anything you wanted to. I mean, within reason. So you could offer physio and OT, you could offer a multidisciplinary team meeting, but just explain what that means. You could offer anything you'd want to really, as long as it's safe. So a few examples of ethical scenarios. So you might need to break bad news. For example, someone with a new cancer diagnosis. You might need to explain a medical error. You might need to explain current management and treatment. You might need to update an angry family member. And normally the people, the actors, the actually actors who come to the exam, they're really good and they're really convincing. So you need to um, have established quite a good rapport with them before they actually de-escalate the anger. And then you might also need to discuss DNAR decisions, DVLA regulations, always just know the common ones. So for example, post an MI and syncope versus vasovagal episodes. It's really important to know those. Something else I saw in past tests was also just indications for a post-mortem, um, which is something interesting and I didn't know before. But if you have the past test videos, you could just look that up. Um, really, it's not only ethical scenarios they assess here, it's also just communication. So you might be asked to explain a diagnosis of pheochromocytoma. So it's not only ethical scenarios that get asked here, or you might be asked to explain a diagnosis of PMR, so polymyalgia rheumatica. Yeah. So I guess this is more applicable for the old PACES carousel where they used to have a form and advisor part to it. But I guess it's just always important to know the four main ethical principles, but no one's going to be asking you about them because they're just watching you for 10 minutes. But just something to bear in mind. Um, and then something else which may come up because now they aren't going to be doing a viva in this communication station. They might actually just ask you to consent someone for a procedure. Might just be a routine procedure. So maybe consenting someone for central line, consenting someone for a lumbar puncture. I think that this might be something that they might introduce because there's no other way really of establishing whether you know the principles of consent. So you might have to just show that you are aware that you're assessing the patient's understanding, making sure they can weigh up the risks and benefits of the procedure, they can retain information and communicate their decision, and also just asking about their concern in addition to all of this. So what are they concerned about with regard to the procedure you are offering? So now we'll move on to the stations. So station one, respiratory station, you'll have 10 minutes. So 6 minutes for the examination, 4 minutes for the viva. I think with most of the examination stations, you can, in most cases, get the diagnosis at the bedside just by looking. So it's really important when you walk in, you're going to be really nervous, but remember to look at everything, look around, there are clues. I can't emphasize this enough. I mean, looking back at my exam, I could have probably spot diagnosed most of the things just from looking at the bedside. So in the respiratory exam, so make sure that it looks like you're looking around. So you've washed your hands, introduced yourself, asked for permission, adequately expose them, make sure they're sitting in an upright position, make sure they're comfortable, and ask if they're in any pain. Another thing that I've heard that examiners don't like is if you try and ask questions like, do you have a cough? Or just don't ask any questions besides, are you comfortable? Are you in any pain? This is not a history taking station. It is purely an examination station. So have a good look around the bed. They might have some inhalers. There might be something called an a cappella device, which is used to remove
secretions in someone with bronchiectasis, and then also just looking at the patients themselves. So are they cachectic? They're unlikely to have pursed lips or tripod positioning, because the patients that come to a PACES exam are generally patients who are well enough to get up in the morning of the exam, come in as if they're coming to a clinic. So it's generally going to be well patients. But do remember that if your exam center is based at a hospital or is right next to a hospital, for example, mine was at an education center quite far from the nearby hospital. So I was fairly sure that these are going to be stable, well patients who can come in for an outpatient clinic. But if your exam is at a hospital, they could, if a patient, a stable patient who is meant to come in, just is a no-show on that morning, they could just bring in a patient from the ward. So this is something to bear in mind. So the signs you look for, if this is just a ward patient and the patient hasn't showed up, is you'll see they'll have a hospital name band on. They'll have a cannula. These are not normal things of the normal PACES, well PACES patient that would just come from home. So 95% of the time, you just have a stable patient who won't have many signs of being unwell. But if you do get a ward patient, just look out for, for example, here, I'll just get the pointer out, the wristband or cannula or SATS probe or whatever else, or hospital gown. I guess another important thing is always just take the gown off. Never examine over the gown or over any clothing. And also when you're asking them to, take their gown off, make sure, in females, you're covering their, you're exposing them in an appropriate manner. You're not just leaving them exposed for the whole examination, just for when you're looking at the chest, and you cover them up at the end. So clues on inspection, there might be some face masks, there might be peak flow meter, inhalers, or a nebulizer. Looking at the hand, so I normally move from just looking at the surroundings, introducing myself, looking at the surroundings, to looking at the hands, and I do this for all examinations. I start with the hands. So another thing is what I've seen from running PACES teaching is that it's really important to give clear instructions to the patients. So you could say, please show me your hands, or please can you copy what I'm doing. So you could show them that your hands are outstretched like the man in the middle of the screen, and ask them to do the same. But just remember that generally PACES patients who've been in the circuits or running the exams for many years, they know how the examination process goes. So if you just give really clear instructions, so please outstretch your hands. I want to check if you have a tremor. They'll be able to do everything you ask of them. So looking at the hands, what are we looking for? So evidence of clubbing. You also just look for asterixis, which is highly unlikely in the PACES setting, which would indicate carbon dioxide retention. You can also look for a tremor if they're on salbutamol nebs or inhalers, nicotine staining, muscle wasting of the palms, so that could indicate lung cancer at the T1 level. Yeah. And then moving on, always important, even in the respiratory exam, feel the radial pulse. Have a look at the respiratory rate. And then the picture on the bottom right of the screen is just showing yellow nail syndrome. So it's a triad of yellow nails, lymphedema, and pleural effusions. And this might be a really well patient who could come in who has a diagnosis of yellow nail syndrome. So just having a look at clubbing. So make sure you know what clubbing looks like. I'm sure everyone's seen clubbing. And if you're unsure if there's clubbing, you would do Shamrat sign. If there's overt clubbing, I don't see the need to do shamrod sign. It's more for the early stages of clubbing where you're unsure as to whether or not there is really clubbing. And one of the earliest signs of clubbing is just sponginess that's felt at the base of the nail. So moving on to just knowing causes of clubbing. So just be really clear on all the different causes, especially for all the other systems. Then I'd move to the neck and face. So can anyone tell me what they see here? You can type it in the chat or unmute yourself. So it's this one with the laser pointer, the top left image of the man's eyes. Anyone see anything abnormal? Or is it a normal pair of eyes? Okay, so this is the Horner syndrome. You can see that there's partial ptosis of this lid, and the pupil, although it's quite difficult to see, it looks a bit smaller. There's some meiosis of this pupil. The next picture here, anyone knows what this is a sign of? Redness of the tip of the nose. Here, this is showing lucus pernio, and it's found in sarcoid, sarcoidosis. This is just showing tracheostomy, which can come in if the patient is really well and has a long-term trachean, but also less likely. This is just showing some cyanosis, purulent sputum, wasting, and a Virchow's node, which is more with gastric cancer. So what you're looking for in the face, you're looking for just general things like your pallor, cyanosis, looking in the mouth, seeing whether they're well hydrated. Then looking at the neck for cachexia, feeling in the neck for nodes. So what I normally do is I move up after the hands, move up to the arms, into the neck. Feel the nodes. Always ask them to lean forward when you're feeling the nodes, and feel from the back when you're feeling the neck nodes. And then I move on to examination of the back. So that's how I like to do it, because I feel like the more yield is from the back. The more information whenever I've examined someone, is always in a time pressured situation, is starting the examination of the back and then moving to the front. So now just know your different chest shapes. So someone with COPD is going to have a barrel-shaped chest. And then the next things you'll do are feel for the trachea, do the chest expansions or movements, and then also vocal fremitus or resonance. I'd say pick one of the two and do one of them instead of doing both of them, because doing both of them is not really going to give you any more information, and you might just not end up finishing the examination. And then finally, just auscultating. It's really important to remember when you're auscultating to listen at the exact same point. So if I'm auscultating here, so firstly, don't auscultate over the scapulae. So if I'm auscultating here, I'd want to auscultate here, here, here. You just pick the same points because you're comparing like for like in terms of the lungs. Same with percussing. So make sure you're in between the rib spaces when you're percussing. Make sure you're not percussing on bone. So an easy way you can do it is just place your finger, the finger that you're going to percuss onto, in between the rib space, and then you will never go wrong. So auscultation, so vesicular breath sounds are the normal breath sounds we should all have, and it's a good idea to just listen to your own breathing as well. Vesicular breath sounds should be throughout your lungs. Bronchial breathing, which isn't on here, but if you want a good example of bronchial breathing, it's the type of breathing you'd have when you listen over your trachea. Wheeze is, I'm sure all of you have heard of wheeze. You can have a cardiac wheeze, or more commonly, the wheeze associated with asthma. Stridor is highly unlikely to be in PACES unless they have some chronic pathology with the upper airway. Crackles, so it's really important to describe where in the respiratory cycle they're happening. So are the crackles in inspiration, expiration? Are they throughout? Are they fine? Are they coarse? And another important thing is ask the patient to cough and make sure, you know, you're assessing whether or not the crackles move or change after coughing. Because true interstitial pathologies, if the on coughing, the crackles will actually no longer be there. I mean, true interstitial pathology on coughing, the crackles will still be there. With other pathologies, where it's just some secretions in the airways, the crackles will no longer be there after coughing. So the end, once you're done with the examination, so these are just common tests you'd probably mention in the respiratory exam. So don't forget sputum. I guess what's missing on here is bedside investigations like an ECG, full set of observations. Some people like to say before they start investigations, they say things like, I'd like to complete my examination by taking a full history and obtaining a full set of observations. This is quite good, something you could say. Don't ever forget bedside peak flow or formal lung function tests, blood tests, and then imaging. So chest X-ray, CT chest, and just know the difference between, you know, an HRCT and a plain CT chest or a contrast CT chest, and when you would need them. Again, for management, I think the most important question is, do they need to be admitted? And you can offer any type of safe follow-up. So you could say, I'll just bring them back if it's a well patient, not in respiratory distress, or you know, you think maybe they have pneumonia, but their curb score is going to be really low. You could just discharge them with safety netting if regarding, you know, the danger signs of worsening shortness of breath, worsening cough, or blood in the sputum, what to do. If someone is more unwell or you need to exclude something like a pulmonary embolus, don't forget you could bring them back to STEC or ambulatory emergency care. So there's just things to think about in the exam which you could offer. So just the extra step for the respiratory exam is looking for features of the underlying diagnosis. So if you see someone with COPD and maybe a lobectomy scar, think about what could this be? They're a smoker, maybe they have cancer. Are they cachectic? Is there clubbing? Do they have lymph nodes? Do they look like they've had a mastectomy? Is there evidence of lobectomy or a pneumonectomy even? Or maybe they've just had the lobectomy because of COPD and bullous lung disease. So there are multiple different reasons. Another thing to always mention and to do in your examination is, so after you've examined the back, go to the front and do the same thing you've done at the back, but obviously just choose fewer points to listen. So maybe just listen to the upper zones, mid zones, lower zones, whereas in the back, maybe you've listened to 4 different areas. And always just quickly put your stethoscope onto the pulmonary valve and listen for a loud P2 or for features of cor pulmonale. And when you're ending your examination, always just check for pedal edema, because this will show the examiners that you're not only getting the diagnosis, but you're looking for features of severity of the diagnosis you're offering. Infections, less likely in PACES setting, but if you're having apical signs only, it could be TB, if it's pleural effusion, the lymph nodes. Also with infections, always keep HIV at the back of your mind. And then connective tissue disease. So did they have any deformities of the hands indicating rheumatoid arthritis? Were there any rheumatoid nodules, rashes in SLE, or tight, shiny skin and scleroderma? And then congestive cardiac failure, look, you would have looked for raised AVP. Cardiomegaly, I can't really remember why I put this on here, but that's more chest X-ray finding. You wouldn't see that on examination. Another important one is cystic fibrosis, because they can be really well, and you might come across a CF patient, especially in PACES courses. They're generally very young, small stature, have clumping on the fingernails and or toenails, and have a peg for feeding and lots of chest scars from previous surgeries. So summarizing your examination findings, there are two different ways for doing this. I prefer this way. But the second way, this way is better if you're quite sure of your diagnosis and you're going to go for it. This is the way I'd suggest. So I've examined this 55-year-old gentleman, and he has signs and symptoms of an acute exacerbation of COPD or just COPD evidenced by, and you just list all the evidence you have for this. Another important thing is when you're presenting your findings, don't start with what there isn't. So I wouldn't start with, I've examined a 55-year-old gentleman who is not in acute distress, not using accessory muscles. Don't start with what is not there. Start with what is there. And at the end, you could say, importantly, he's not acutely distressed because he's not using accessory muscles. He was able to talk in full sentences when I introduced myself. And then you could also mention a differential diagnosis, because even if your main diagnosis is COPD and that's incorrect, as long as you mention the diagnosis somewhere in your differential, you will still get full marks. So it is good to always mention at least 3 differential diagnoses. And then you'd move straight on. So you wouldn't want to give the examiner time to ask questions. So this is what I did. So I'd say, I've examined this gentleman. He has X, Y, and Z. My differential diagnoses would include a community-acquired pneumonia or whatever else you want to say. And then I would move straight on by saying, I would like to perform the following investigations, and then I just list them. And I wouldn't say why I wanted to perform the investigations, because the examiners will probe you about this later. And you're trying to get through everything to get your examination, to get all the points. If they want to ask you a question, for example, why are you looking at the hemoglobin? They can ask that, and then you'd answer polycythemia, which can happen in COPD. You don't need to say, I'm looking at the FBC to look at the white cell count and the hemoglobin, because then you're never going to get to your examination and then you'll lose all those marks. So just say what you would do, get on to management, and then if they had further questions, they'll ask you questions. If you feel like they're asking you very difficult questions, it's generally a good sign. It means you've passed, you've done really well. They're just trying to test your knowledge. And then mention your management. And I think another important thing in management is always start with, for some cases, you could have conservative versus surgical management. Other cases, you could have non-medical versus medical management. And in non-medical management, they love to hear the words multidisciplinary team approach, and mention who would be involved in that multidisciplinary team, mention education, prevention or risk factor, counseling on how to assess risk factors, and also, for example, smoking cessation, etc. That's really going to get you all the marks. It's not only about medical management, which I know they know, all of us know. Moving on. So if you're unsure of the diagnosis, another way of presenting would be to say, I've examined this gentleman's respiratory system. He has the following clinical features. Putting this all together, I have a differential of community-acquired pneumonia, infective exacerbation of COPD, and you can list whatever else you want. But if you're quite sure of the diagnosis, I think go with the first one. It just makes you seem very confident, like you know what you're doing. I guess the first one is risky if you have the wrong diagnosis, but always offer differential, and then I think you're covering all angles. So possible respiratory cases, common ones that come up, interstitial lung disease, because they're really well patients who can just come in, bronchiectasis, COPD or asthma, a pneumonectomy, lobectomy, and also pleural effusions, and someone who has had a chronic pleural effusion and they've been investigated. They're really well, and they can come in from an outpatient setting. So we'll go through a few cases now. So interstitial lung disease, a few hints at the bedside. Do you see some supplemental oxygen? Is there surrounding equipment? So nebulizers, inhalers. So that would suggest COPD rather than interstitial lung disease. Do they have clubbing? So are they cyanosed? Very unlikely in a PACES setting, but just make sure you're showing that you're looking at the lips. You're asking to look at the tongue. And then expansion. So really important to practice how you do your expansion, and that you're actually doing it in order to assess whether both sides are moving symmetrically, and you're not just doing it for the sake of putting your hands on the chest, which is a tricky thing. So the next time you examine someone and check their chest expansion, actually think about what am I looking at? More than, oh my gosh, I'm so nervous, I'm just putting my hands on their chest and hoping something will happen. You actually need to be thinking about what you're looking for when you're doing the various things. And then, of course, the clincher for ILD case will be the Velcro-like inspiratory crepitations, the fine end inspiratory creps, which are the hallmark of ILD. In terms of a differential, just keep it simple. Think about upper versus lower lobe predominance. So if you have someone with lower lobe predominance, think of causes like rheumatoid arthritis, idiopathic interstitial lung disease, sarcoidosis, and then go through the causes of upper lobe predominance. You can also remember that some might have, I think someone is trying to say something. Forgot what I was going to say. Okay, so I guess the important thing is when you're looking for, is this upper or lower lobe, and you think the underlying diagnosis might be rheumatoid arthritis, you can mention that. You can say, well, I think this is a case of interstitial lung disease, and I believe the underlying diagnosis might be rheumatoid arthritis based on the deformities of the hand. So maybe they have ulnar deviation, they're rheumatoid nodules. And by saying all of this, you've gotten the diagnosis because you're putting it all together. And there's no reason why you shouldn't pass unless you've caused some harm to the patient or done something else, which is extremely unlikely. Systemic sclerosis, something else that can come in very easily from an outpatient clinic setting. So look for shininess of the skin thickening, Raynaud's phenomenon, but you might not see it on the day of the exam. It's more to keep in mind in station 5. If you think someone has shortness of breath, to always ask if they've noticed changes in the color of the fingers at any point. Sarcoids, always look for enlarged lymph nodes, erythema nodosum on the lower limbs, or any eye signs, which is more pertinent for station 5 when you can ask, do you have dryness of your eyes? Have you had any blurring of your vision, etc.? So bronchiectasis, again, look at whether they have any breathing support. Look for surrounding equipment, so nebulizers and something called an a cappella device, which helps remove secretions. Clubbing, look for scars, reduce chest expansion. And the key for bronchiectasis is really coarse, harsh crackles, and they don't clear when the patient leans forward and coughs. Differentials for this, so if they're really young, small stature, have other abdominal scars like a peg tube, think of CF. But also just break it down into different categories. So this is how I broke mine down. congenital versus mechanical, childhood infections, overactive immune system, underactive immune system, which I found really useful. So moving on to specific syndromes. So as I said about CF, young patient, they're thin, normally small stature, they are likely going to have oxygen or oxygen nearby, clubbing of the fingernails, indwelling lines, so they might have a midline or a Hickman line. And you don't need to know whether it's midline or Hickman line. You could just say, I can see evidence of a tunneled line, or I can see evidence of a long-term line. PEG or RIG. So the difference between PEG and a RIG, so one is radiologically inserted and one is just percutaneously inserted. You don't need to know the difference at the exam, whether it's a PEG or RIG. You could just say, I see a feeding tube, but there are ways of, I think I have a picture later on about differentiating between a PEG and RIG, just very subtle features. Also in cystic fibrosis, look for signs of chronic liver disease, and also look for crayon at the bedside. It's a big one. They might just leave the crayon there. Finger prick marks, insulin needles or BM equipment, and look for scars. So really important in the female to look under the breast for a clamshell thoracotomy scar, because with wet lung disease like cystic fibrosis, you generally won't have one lung transplanted because there's a high risk of that of infections from the lung which isn't transplanted, then just affecting the new transplanted lung. So you'll generally have both lungs being transplanted. And then in terms of management, so again, always mention multidisciplinary team, education on diet or whatever else you want to say, physio and OT, especially chest physio, addressing risk factors. So making sure they're immunized, they stay away from people who have colds or flus or bad infections, and then the medical management, so nebulizers, inhalers, mucolytics, oxygen, NIV, nutrition, crayon, and managing their diabetes. Other specific syndromes, so cartilaginous syndrome, so ciliary dyskinesia, but important to note here that the patient might have dextrocardia, which would give you a big hint. So when you're listening for the loud second heart sound, you might think, oh, I can't actually hear the second heart sound. Or when you're feeling for the apex beat, which you should also do in the respiratory exam, you might not be able to feel it. So you should start thinking about, it's more commonly in males, evidence of dextrocardia, give it as one of the differential diagnoses. Because again, this could be a really well patient who could come in. Connective tissue diseases, so look for peripheral symmetrical deforming polyarthropathies, cutaneous features of lupus, and then yellow nail syndrome, which we've touched on already. So in case of COPD or asthma, there might be really, really subtle signs. You might only have, an inhaler at the bedside or a sputum pot. Look for the nicotine starring of the nails, or look for the barrel-shaped chest, cachexia, tremors from the use of bronchodilators. Check whether or not they're hyperinflated. Does the liver feel like it's pushed down? The chest might really be clear if they're, well-controlled COPD, or they're not having an acute exacerbation, or the asthma is really well-controlled. You might have nothing to hear on the chest. But again, remember that you're going to say in your differentials that this could be asthma or COPD. You won't add in that this is bronchiectasis or that this is interstitial lung disease, because it's a fairly normal examination and there'd be no need. I see someone has added something to chat. If the patient declines your offer of chaperone, would you say you'll still do it? I don't see why they'd ever need to be a chaperone in PACES, because you aren't doing anything like a digital rectal examination or a breast examination. You don't need a chaperone, and the examiners are right there. I don't think you need to ask for a chaperone with regard to PACES. But if you're doing any type of more private or invasive exam, like digital rectal examination in practice, I would always offer a chaperone and just tell them that, this is common practice to have a chaperone and just get one anyway. Okay. So other differentials for wheeze, asthma, heart failure, you can get it with bronchiectasis and mucus plugging. So I think a common thing people say is, they had COPD in the exam, but they're not sure if it was COPD because the patient was really well. So again, just mention differentials and look at the clues at the bedside. Is there an inhaler? Do they have some nicotine tar staining? And put it all together and give your differentials. Also, look closely for scars on the chest. Look into the axillae for scars. Look for VAT scars. Yeah, we'll go on to this next. So, case for a pneumonectomy. So again, by looking at the inhalers and sputum pot, it's giving you clues as to the underlying diagnosis. So if they have a sputum pot at the bedside, if you can see some purulent sputum, if you see that they've got a rig or peg, it's all giving you clues that this could be cystic fibrosis. So again, look for features for the underlying cause, feel for the nodes, make sure you're actually feeling for nodes and not just feeling for the sake of showing the examiners that you're feeling. And in terms of scars, so look for lateral thoracotomy scar, VAT scar, which is video-assisted thoracoscopic surgery, chest drain scars, so tiny scars in between the ribs, which are probably healed and could show that maybe there have been recurrent pleural effusions, or just try and think about why certain scars are where they are. In a pneumonectomy, the trachea might be pulled towards the side of it. So the side of the pneumonectomy always pulls the trachea towards it. Look for asymmetrical chest wall movement. So from the edge of the bed, ask them to take a deep breath in and out. Also listen out for reduced vocal resonance over the side of the pneumonectomy. I prefer vocal resonance over, so tactile vocal resonance over vocal fremetus. I don't know, it's just, I find it more useful. In terms of auscultation, so in a pneumonectomy, there might be absent breath sounds over the whole hemithorax. And they can be, which can be really confusing when you hear it. They can be bronchial breathing in the upper zone on the side of the pneumonectomy, because once the lung is removed, the trachea kind of gets deviated. So, and that bronchus, so whether it's the right or left main bronchus, might have shifted. And like I said before, bronchial breathing, if you listen over your trachea, you will hear bronchial breathing, and that's what you should listen for. When you think something could be bronchial breathing, just have a listen over the patient's trachea and compare that sound. In a pneumonectomy, the upper zone, you could have bronchial breathing because of this pushing of the trachea onto that side. And also, again, listen in the lung you think is the native lung, to try and listen for the underlying pathology. Do you hear really coarse crackles? Could this be bronchiectasis? And this is why they had a pneumonectomy. Are they wheezes? Could this be asthma or COPD? So indications for pneumonectomy. So we can see a few scars here, pneumonectomy scars. Local bronchiectasis, uncontrolled hemoptysis, early non-small cell carcinoma, lung volume, reduction surgery in COPD, a lung abscess, trauma, a solitary pulmonary nodule of unknown cause, cystic fibrosis, where maybe just one part of the lung is just really infected, really damaged, and they've just removed that I mean, one lung is just really damaged and they haven't been able to do a lung transplant yet. They might do a pneumonectomy on one side. And previously, maybe 60 years ago, treatment for TB would be pneumonectomy. So just keep that in the back of your mind. So lobectomy, so that's just removing one of the lobes. So differentiating between two. I don't think it's necessary that you choose one and stick with it. So you could say my differentials would include a pneumonectomy and lobectomy. I think that's perfectly fine. If they push you on, is this a pneumonectomy or lobectomy? Just try and synthesize what you found. So is the trachea shifted to towards the side of the pneumonectomy? I mean, towards the side of the, where the scar is. That's a good indication it's a pneumonectomy. A lobectomy, unless it's an upper lobe lobectomy, is much less likely to cause any shifting of the trachea. So that's an important clue. Is the trachea and apex beat shifted to the side of the scar? If it is, it's likely a pneumonectomy. And then on the side of the pneumonectomy, you would have reduced expansion. There's dullness to percussion. And there's dullness to percussion because the body remarkably fills that empty space with some type of serous fluid. And sometimes they also inject certain things into the empty cavity. And there will be no breath sounds in the lower zones with maybe some bronchial breathing in the upper zones. And these are all things you could say to the examiner to substantiate, I think it's a pneumonectomy for this, and for these reasons, but in my differential, it would also be a lobectomy. And you'd get the top marks. Just see another question in the chat. Okay, just says okay. So lung transplant. You can have a single lung transplant or double lung transplant. In a double lung transplant, you will see the clamshell thoracotomy scar, which is shown here. This is why it's really important to ask if they're female, to just lift the bra strap up and have a look under, because you might miss the only sign in your whole station, in your whole respiratory examination station, which might be that. And the breath sounds might sound beautiful and normal, vesicular, because they've had a lung transplant and it's bilateral. So if you miss the scar, you're not going to put it together, you're not going to know the diagnosis. And then remember that you can also have a single lung transplant. There you would just have a single thoracotomy scar, and differentiating between causes of a single versus double lung transplant. Single lung transplant is done in something more dry lung conditions like COPD or pulmonary fibrosis, whereas a double lung transplant is in more wet lung conditions like cystic fibrosis, bronchiectasis, and sometimes pulmonary hypertension. Another important point is if you think they've had a lung transplant, again, like we'll touch on for the renal exam, look for features of them being on immunosuppressants. So do they have features of skin cancer? So basal cell carcinoma, squamous cell carcinoma. Do they have a tremor because they're on tacrolimus or cyclosporin? And we'll go through a few of these a bit later. So just a note about pleural effusions. You could have a pleural effusion if the patient's really well. Again, the key signs would be pleural effusions push the trachea away, whereas pneumonectomies pull towards. You will have the stony dullness on percussion. Always just know about the modified Lights criteria because they will definitely ask about it. Even if you don't have a pleural effusion, some examiners just love asking about the modified Lights criteria. So know the different ratios. Yeah. So moving on, if you had a case like this, so an elderly gentleman with a thoracotomy scar, barrel chest, and nicotine staining, what could the diagnosis be? Really simple.
Anyone? Okay, so good. Could be COPD, a smoker with COPD, and maybe he's had some lung volume reduction surgery in the past. So this one, young patient, small stature, finger clubbing, and a peg tube. The answer could be cystic fibrosis. So like I said earlier, PEG is a percutaneous endoscopic gastrostomy. So it's inserted via telescope almost down the esophagus, whereas the rig is just a radiologically inserted gastrostomy. And there's subtle differences between a rig and a PEG tube. So a rig normally has this round thing that's attached to the skin, flush, so it's flush on the skin. And whereas a peg feeding tube has a single lumen end or sometimes double, versus a rig which normally has three. It might just be safer if you're unsure to just say, I see evidence of a feeding tube, and you'll be fine. So moving on to stations 2 and 5. So like I said before, you now get 20 minutes, 14 minutes for it's actually sorry, not 14 minutes for the consultation. It's 15 minutes for the consultation and 5 minutes for Viva. So I think the approach for the consultation is start with 1 or 2 open-ended questions and then move on to more closed-ended questions. If you keep asking open-ended questions, you're going to run out of time and never get to the diagnosis. So you could maybe say, the stem outside the door might say, this is a 55-year-old with shortness of breath. So you might ask, can you tell me a bit more about your shortness of breath? That's your first open-ended question. Then you can think of one more and then move on to, when you're trying to assimilate what could the differential be, you will move on to more close-ended questions. Also, when asking questions, something we do every day is asking 2 questions at once. So for example, do you have any loss of weight or change in your bowel habits? That's 2 questions in one. It's a no-no in PACES. Just ask, have you noticed any loss of weight? Wait for the answer. Then, have you noticed any change in your bowel habits? Just these little tiny things. And you can show active listening, maybe once or twice at the end of the history taking, by saying, okay, is it okay if I summarize what I think's going on? So you've said you have 2 weeks of shortness of breath with this, and this. It just shows the examiner and patient that you're listening, but also it's a good summary for yourself to keep you focused and keep you thinking. So this is something I used in all my station 5. So I just say, so in summary, you have this, and this. Is that correct? Just to make sure you've gotten the right information. Also, it's a very stressful environment, and this sometimes it's just giving yourself, something to remember, what's going on and keep you focused. Another thing the examiners love is to always just be systematic. So start with, presenting complaint, history of presenting complaint, move on to the systemic inquiry. Don't jump around and at the end asking social history, just say, oh, sorry, I've just forgotten to ask this, and this. Or when you've said thank you to the patient and said, you've mentioned your management plan, you've thanked them, and it's the end of the consultation, then you say, oh, wait, sorry, I've forgotten something. That just seems very unprofessional. So try and, when you're outside the station, plan, maybe write up some headings. History of HX of PC, systemic inquiry, social, just so you know what you're going through when you're in the station, because you can look down quickly at your piece of paper and it's
the examiners don't mind that, as long as you're not just reading off your piece of paper and not maintaining any eye contact. In terms of examination, perform a focused examination. So examine the system you think is pertinent. So, for example, you have someone with shortness of breath and chest pain. I would examine the respiratory system, but also the heart. And because you guys have more time, there's really no excuse for examining the correct systems. If you have someone with, I just think of something that might be a bit tricky to know what to examine. Okay, someone with a headache, and you see tons of equipment at the bedside. So you see Snellen's chart, you see a fundoscope, you see tendon hammer, you see everything there for neurological exam, but the person has a headache. You need to decide, is this a headache from intracranial pathology, from the history, or is this more from ocular pathology? And then decide, what do you think is going to be the safest thing to examine in your limited amount of time? So you might say, okay, I'll start with a quick Snellen's chart, just looking at the last line of the Snellen's chart, seeing if their visual acuity is fine, shine a light in their eyes. Offer fundoscopy. You might see that the examiner says, assume fundoscopy is normal, and do a quick neurological exam. So important things in station 5 is you decide what you want to do. It's your time. So I would start with the pronated drift, because that's a good show of, is there any associated weakness of the arms? And then you could check the reflexes. But if someone has a headache, I'd more want to make sure they don't have any ocular nerve pathology, so cranial nerves 3, 4, 6, neck stiffness, photophobia, things like that. And maybe just a few screening tests like a pronated drift or checking the reflexes, or even just doing the checking for the Babinski sign is a good way of doing it. So the key is it's just a focused examination, and you should already have your diagnosis from the history. Importantly, always address their concerns. So ask them. The examiners love to hear when you've asked the patient, do you have any concerns? That is automatically a tick on the piece of paper. Don't ask it in a roundabout way, like, is there anything else I could help you with? Some examiners are switched off. They literally will not count that as a concern just because they haven't noticed it. So just ask the patient, do you have any concerns? Is there anything I haven't addressed? Anything else I haven't addressed? And then in terms of management, just be practical. Do they need admission? Do they not need admission? Do they need follow-up in STEC today, or do they need follow-up in a couple of weeks? Always arrange follow-up and safety net. And finally, just ask if they have any questions, or just normal things you do in everyday practice. Something I found quite useful is just a way to structure your answers in terms of when you ask for a differential diagnosis. You could just look at something like the surgical sieve, which looks at, so it's the mnemonic of vitamin C, D, E, F, vascular causes, infective causes, traumatic causes, autoimmune causes. Again, in PACES, if you're thinking of a cause and it's a traumatic cause, this is a medical exam. That's not going to be the one. Autoimmune, metabolic, iatrogenic, neoplastic, congenital, degenerative, endocrine, functional. So possible station 5 cases. I know that a quick and easy one is always some type of joint pathology or joint pain. Headaches can come up, shortness of breath, TIA, ankylosing spondylitis, electrolyte abnormalities. Literally anything can come up in station 5. But if you have a look at past tests online. They'll give you the top 10 cases or 5 or 10 cases for each diet. And that's quite a good indication of, what you need to know, what top 5 or 10 cases, are really common. So an approach to arthritis, take your history, make sure you've done a good systemic inquiry, do a quick connective tissue disease screen, because many connective tissue diseases can also have arthritis as a feature. Then in terms of examination, just stick with look, feel, and move. Firstly, look. Before you feel anything, ask about pain. You don't want to just start moving the patient's hands around and they've got active synovitis and you're making them, you definitely fail because you will, for patient welfare, you lose marks. And I think if you lose 2 or 3 marks on patient welfare overall, you will fail. So always ask, do you have any pain in your joints? Could I have a feel of your joints, or can we see how they move? Again, concerns, management, follow up. So in terms of the arthritis history, ask questions that's going to help you, narrow the differential. So timing of the symptoms, was it sudden or gradual? What time of the day is it better or worse? Is it intermittent or constant? Has it progressed? I just see a message in the chat. So is it intermittent or constant? Has it progressed? Have there been previous episodes? How have the previous episodes been managed? Have there been any relapses? Also, you could ask, oh, so Dr. Addy has asked, you don't want to interrupt the patient, but you're running out of time to ask planned questions. Can you write these down and hand these notes to the examiners on your way out? No, please don't write any notes and hand anything to the examiner, especially in PACES. No, I wouldn't do that. You need to develop a way of knowing how to interrupt a patient. So you would maybe say, I mean, it's a skill you learn over time, really. You might say, well, we're running out of time, or would you mind if we talked about your shortness of breath more before we moved on to whatever they were discussing? There are ways of doing it, but in PACES, the patients are really well prepped. They will be told, don't give out this information too easily. Only tell them your past diagnosis of, I don't know, rheumatoid arthritis if they ask about your morning symptoms, or if they ask which joints are involved. The patients basically have a whole briefing, so they get their own little brief of what symptoms they have, what information they can willingly give, or when they could give certain information. So for an angry relative example, it might be said to them that, once you've only established a good rapport, you think they have a good relationship with you and they've calmed you down, then turn around and stop being angry, for example. So you'll see that there'll be a certain point where they might start giving you more information once they've kind of assessed how you've been asking them questions. And I don't think they would go too off topic because they've been prepped for the exam. And you'll see that a lot of the time patients are really helpful in the exam. So they're literally trying to get you through everything and they're trying to help you, it's quite funny to see. So some of them will, when you're examining their face, they'll start opening their mouth already, which is what I found. So I'd ask them to pull down the eyelid and they're already pulling down the eyelid. So you can just say pull and the eyelid's already pulled down because they know the sequence of the examination. I guess this is also why it's good to follow a systemic but common way of examining. So if you follow the past test videos, for example, I don't think you'll go wrong. That's just a routine way of examining. It's when you're doing something out of the usual. It might be, normal for you to listen and then percuss. Okay, but that's not the normal way of examining. And it might be a red flag in a way to an examiner, which would make them watch your watch everything you're doing in terms of the examination. So moving on, I think we digress quite a lot. Arthritis, history. So also ask about the pattern of joint involvement. So which joints are involved? Are they small or large? Hands, feet, elbows. You can ask them anything you want about their joints. And then ask about whether it's unilateral, bilateral, the order of involvement of the joints, if they have associated back or neck pain. So whether the pain or stiffness is in the morning or the evening, whether there's redness, deformities, nodules they've noticed. And importantly, a really important one is loss of function, what they can and can't do. Past medical history, you can ask about past diagnoses. Again, in PACES exams, the patient can't lie to you. So if you ask, do you have rheumatoid arthritis? Okay, and you think that's the diagnosis. They won't lie and say no, but they might say, sorry, doctor, I don't remember. That doesn't mean the diagnosis is not rheumatoid arthritis. It's just because you can't ask them, is your diagnosis this? That's you could say, have you ever been treated for rheumatoid arthritis in the past? And then they might answer, actually, yes, I have. Or, oh, I've heard something about that. Or maybe they might still say, I don't know, because they don't want to give you all the answers and you need to make your own assessment at the end. But if they say no to something, for example, um, have you had joint surgery in the past? If they say no, they really haven't had joint surgery and maybe you're going down the wrong route or the wrong differential. Or for psoriasis, if you ask, have you had any rashes in the past or any scaly skin, and they say no, you can comfortably rule out psoriasis. If they say, I don't remember, or I could have, it could still be a possibility, if that makes sense. In terms of inflammatory bowel disease, always just ask if they've had any bowel problems, bowel surgeries, um, and autoimmune diseases. Coming up in a few slides, I have a really good autoimmune disease screen, which is just something to bear in mind for anyone who sounds like they have some type of rheumatological condition going on. So you can ask them about their current medication, and this is where you'll get a lot of information. So most patients will just hand you a piece of paper they came in with, and it will say all the medication, which is what happened to me in my exam. So I just got handed a little piece of paper, and it said all the medication the patient was on. So if you have a case of arthritis and you see methotrexate, sulfasalazine, then you're going down, you're thinking, okay, this could be some type of rheumatological condition, this could be RA, just have the differentials you're thinking about. Also, a common mistake people make is they see methotrexate and they think, okay, this is rheumatoid arthritis. It might be a complication of methotrexate use. It might not be rheumatoid arthritis. There are many other reasons for someone being on methotrexate. So just keep that in mind. And then finally, just in terms of social history, always ask about, alcohol, smoking. And when you're asking about drug use, never say, is there any illicit drug use? Because they're definitely not going to open up to you. You could try saying, do you use any party drugs? Do you use any recreational drugs? And you could normalize the question by saying, I do have to ask. This is a question I ask everyone, because you want them to feel at ease, not just, do you use any illicit drugs or do you use drugs? You need to be really specific, because when you ask someone, do you use drugs? They might say, yes, well, I use paracetamol every now and then. Moving on. So just be really sure about, the extra-articular features of psoriatic arthritis. You could have nail changes. They often get nail ridging. You'll see the evidence of the psoriasis on the skin, red or painful eyes. evidence of plantar fasciitis, Achilles tendonitis, dactylitis. So how you could get to this is you could ask, have you ever had a swollen finger or toe before? Have you had really painful heels or really painful ankles? And then if you want to assess spondylitis, you need to ask specific questions like, when is the back pain worse? Is it in the morning, in the evening? Does exercise help? Are you stiff in the morning? How long are you stiff for? Do you wake up in the night? So this is quite an important question about night pain because it could be a red flag indicating an underlying malignancy. Pain in the buttocks, so you're assessing for sciatica, and then neck pain, if you're looking for, features of cervical spondylosis. Another important point is extra-articular features of rheumatoid arthritis. So always ask about systemic upset, fever, night sweats, loss of weight, fatigue, lymph nodes, Raynaud's phenomenon, so rashes, photosensitivity, hair loss, ulcers, dry eyes, red, painful eyes, or a change in vision. Cardiovascular system, so chest pain, shortness of breath, coughing, dysphagia, weakness or sensory changes. And this is because with rheumatoid arthritis, the extra-articular manifestations could be episcleritis, scleritis, cardiovascularly, they could have a pericardial effusion. They are more prone to accelerated atherosclerosis. They're more prone to developing pericarditis or vasculitis. In terms of the GI tract, they can get esophageal dysmotility, hepatosplenomegaly. Hematologically, you need to always just be aware of Fouty syndrome, which is the triad of rheumatoid arthritis, splenomegaly, and neutropenia. In terms of the lungs, you could get interstitial lung disease, pleuritis, pleural effusions, and then neurologically, they can get cervical myelopathy, a big one not to miss. So always try, if you think someone has rheumatoid arthritis, try and ask if they've had neck pain, any weakness. And you can also get mononeuritis multiplex or peripheral neuropathy with sensory changes. And then just in terms of the deformities for RA itself, I think I have a table coming up going through this, but you basically just be looking for ulnar deviation or subluxation, dislocation at the metacarpophalangeal joints, swan necking, which is a flexion deformity at the distal at the DIPJ with a hyperextended PIPJ. So it looks like literally like a swan neck. Or a botanier deformity where there's an extended DIP joint with a flexed PIP joint, or Z neck deformities. Also, you don't need to know the name of the deformities. Don't waste time, trying to figure out, is this swan neck, is this Bottonier's deformity? You could just say they're features of rheumatoid arthritis because there's more proximal joint involvement. There's ulnar deviation. There's evidence of maybe a swan neck deformity. Because again, the examiners are never going to be consultants in that specialty. So it might be a gastroenterologist doing the rheumatological exam for station 5. So they might not even be sure. So the hand examination in general, I decided to put this in because I've seen the hand examination being done really strangely. So just stick to look, feel, move, and you won't go wrong. So looking, you can get a lot of information from looking. Look for scars. Do they have evidence of an arthrodesis? So do they have evidence of a joint replacement? Are there skin changes? Do they have skin thinning, scaling, plaques? Are there color changes? Are there deformities? Or does the skin look really shiny? Does it look thickened? Does it look very tight, like in scleroderma? And then also, what are you looking for in the hands? So generally look at the nails, So look at the nails for pitting or ridging, which can happen in psoriatic arthritis. Then look at the dorsums of the hands. Look at the palmar aspects. Have a quick look at the elbows and feel for any rheumatoid nodules. So rheumatoid arthritis, mostly proximal joints. Look for deformities, wasting of the hand muscles, ulnar deviation, psoriatic arthritis, nails for the pitting or onycholysis, scaling and plaques, especially at the elbows, lower back, hairline, or scalp. Osteoarthritis is mainly the distal joints. So look for Heberdin's and Bouchard's nodes. And the Heberdin's nodes are very much, when you feel them, you might confuse them between a rheumatoid nodule, but a rheumatoid nodule is very fleshy and a Heberdin's node is very firm. Also, Heberdin's nodes are mostly on the distal aspect of the fingers, whereas rheumatoid nodules, your common sites of, the elbows. Yeah. Don't forget dermatomyositis, looking for Gottron's papules, mechanics hands, telangiectasia. And if you see all of these in your bedside investigations, you could mention you'd want to do nail fold, I don't know what it's called. So looking deep, looking with it's basically like a microscope looking at the nail folds for any telangiectasia. And then if it's gout, you're looking for the gouty tophi, looking for the common sites that gout affects. In terms of feeling, so always ask about pain before you feel. You're feeling for warmth of the joints, pulses, capillary full time, and you'd only do passive movements if they can't do active movements. We've talked about nodules. And then movements, it's really important with whatever you're doing to just assess main functions. So if you do a rock, paper, scissors, you're basically assessing all the nerves. So rock is median nerve, paper, radial nerve, scissors, ulnar nerve, a quick way of assessing the three nerves. Ask them to squeeze your fingers, assess for carpal tunnel syndrome, so you can do Tunnel's and Phelan side. So Tunnel's, the tapping test, tapping over the median nerve, and Phelan side, so prayer or reverse prayer, and seeing if you can reproduce the shooting pain. Functionality, so you could take a coin to the exam and if you get a rheumatological station, not guaranteed, but could be likely, you could ask them to pick up a coin from a flat surface because that's a really good indication of the type of function they have with their hands. So hands in general, on the left we can see this is the ulnar deviation. So all the joints look like they move towards the little finger. You can see there's some swelling at the metacarpophalangeal joint. If you look closely, there's some wasting here, wasting. These are all subtle signs that you can use. Here, this is a picture of very shiny, thickened skin with swelling of some joints. This is classic scleroderma hands. Looking at the palms, so Dupuytren's contracture, and moving on to, this is very subtle, but there's wasting here. The muscle bulk is not as it should be. And I think that's fine. So more scars, so if they've had tendon release surgery, or carpal tunnel surgery. And this is a table I've made just to summarize differentials you could have. So osteoarthritis is generally monoarthritis or oligoarthritis, whereas rheumatoid arthritis is more symmetrical, it's polyarticular, and psoriatic arthritis could be poly or oligoarticular. Gout is generally monoarticular, and ankylosing spondylitis, again, monoarticular. Distribution, so the only symmetrical ones are really the rheumatoid arthritis and ankylosing spondylitis. Sites, OA is mostly distal hand joints. You can have knee involvement, but again, it's asymmetrical. And generally, patients will tell you it started in my left knee. They'll be able to remember where it specifically started. Whereas RA, as we said before, proximal hand joints, same as, so psoriatic arthritis is also distal, so is gout. And then spinal involvement, so OA can have spinal involvement, but it's non-inflammatory. RA is generally, you can have spinal involvement, but it's mostly up in the cervical area. Psoriatic arthritis, spinal involvement is common, whereas gout, there's no spinal involvement, and ankylosing spondylitis, the hallmark feature is spinal involvement. Then in all of these, sacroiliitis is only common in psoriatic arthritis or ankylosing spondylitis. Skin changes are only going to be present in psoriatic arthritis, enthesitis in psoriatic arthritis and ankylosing spondylitis. The nail changes mainly only in psoriatic arthritis. So I we move on to an approach to headaches, which is another common station 5 topic. So it's important to know that the International Headache Society classifies headaches into primary headaches and secondary headaches. So primary ones are the commonest are migraines and tension headaches. And then you get all your other types of headaches, the trigeminal autonomic cephalgias, which include cluster headaches, paroxysmal continuous hemicranias, and other rarer ones. Then, importantly, secondary causes, trauma, vascular causes, medication overuse, infections. Again, with headaches, I think in PACES, the most important thing is to exclude the life-threatening causes. So if someone has sudden onset headache, they have neck stiffness or visual changes, you could say you'd want to admit them because you want to exclude a subarachnoid hemorrhage. Again, you need to have evidence of that sudden thunderclap headache, which is constant with all the other features. So maybe they've had something like loss of consciousness, focal neurology. Do they have a past medical history of aneurysms or family history of aneurysms? Do they have a history of polycystic kidney disease? Generally, the stem will be something that is something that the case will always have lots of clues to it. So there'll definitely be something on maybe past medical history or family history that's going to give you an indication as to what the diagnosis is or lead you towards the diagnosis. Another common topic is carbon monoxide poisoning. So they have a generalized headache. It's worse early in the morning. You need to be really specific and ask, is the headache worse when you're at home or when you leave home? And also don't just assume that the carbon monoxide poisoning is happening at their house. It could be at work. So ask, does anyone else you know have this headache? And then they might say, oh yes, my colleagues at work have a headache. So you could say, have you noticed when you leave work that the headache improves? So little tricks to just figuring out what the differential diagnosis is. Again, in carbon monoxide poisoning, they might have nausea and vomiting, as well as all the other differentials on this table, really. But the key thing is that they might mention they have pink skin and lips in the morning or facial flushing. They might mention that, oh, my boil has been really problematic recently, or, I've had to buy lots of heaters recently and they aren't working well. they could mention that they feel a bit muddled in the morning, or some type of confusion. They could mention that they feel quite unsteady on their feet or have dizziness. These are all the features of carbon monoxide poisoning. And then in terms of cluster headache, so it's unilateral around the eyes and the side of the head. It can last from 15 minutes up to 3 hours. It can occur multiple times a day. Nausea and vomiting can happen, and there are many associated visual symptoms: red, watery eye. They can have a drooping eyelid, nasal congestion. Tension headache, so it's a band-like headache on the forehead. It's pressing or tightening. It lasts for shorter periods. They're cluster headache. It's not really associated with nausea, vomiting, or visual symptoms. Migraine, so unilateral or bilateral, it's pulsating or throbbing. The patient will mention that they've had multiple previous episodes of this, 4 to 72 hours in duration. They could have nausea or vomiting. They could have visual symptoms if there's an aura. So ask them about any warning signs before the headache starts, the number of episodes they've had, whether they've noticed any associations with the headache. So some people might get a migraine, a premenstrual migraine or postmenstrual migraine. Ask about photophobia, phonophobia. So phonophobia is aversion to sound, to loud sounds, and an aura. Then GCA, generally unilateral, more in people above the age of 50. They can have flu-like symptoms, jaw claudication, proximal muscle weakness. And a quick bedside test, if you think someone has proximal muscle weaknesses, get them, they'll be sitting on a chair already in the station. You'd ask them to cross their arms over their chest and try and get up from the chair without using their arms. And then you can feel over the temporal artery for any tenderness. The important thing with GCA is that if they have any visual symptoms, such as monocular visual loss, or you done fundoscopy and you think there's papilledema, or they have blurring of their vision, you need to admit them for IV steroids. So GCA could really be something that comes up. So other important differentials to mention or rule out would be hypertensive emergencies. So if they have a past history of hypertension, you could ask how well controlled the blood pressure is, what medication they're on. See, there's a question. For osteoporosis, pharmacological treatment, and what's a nephropathic patient? Would you treat, if you're meaning a patient with renal problems? I'm not sure what Dr. Addy means. A renal patient. I think depending on the creatinine clearance, you can look up whether you can use bisphosphonates. Yeah. Okay, then other things to rule out. So dissection, space occupying lesions. So if they have a headache, which is worse with positional changes, or in the early morning with constitutional symptoms. Another common topic is venous sinus thrombosis. So again, here, are they female? Do they have risk factors for being prone to clotting? So do they have antiphospholipid syndrome? In any female, given that you have more time in station 5, I think it would be a good idea to ask about previous miscarriages, because then you'll know you're going down the antiphospholipid syndrome, maybe linked to SLE side of things. Or if they have a headache, you know it's venous sinus thrombosis with the risk factor being antiphospholipid syndrome. And then in a subdural or extradural, just think about trauma. Are they elderly? Do they fall? And stroke, you do this just with your examination. Look for pronator drift, any weakness, any difficulty walking, meningitis and encephalitis. So always on history, just ask if they have fever, neck stiffness, flu-like symptoms, and mention that you would like to check the back of the eye for papilledema. And then I think another really important point is that when examiners ask you, what else could this be? It's normally something not very complicated. Maybe it's something as easy as pathology with the eye, and actually this could be acute angle closure glaucoma. So when someone has a headache, don't automatically think, okay, this is intracranial pathology. I need to exclude intracranial pathology. It could be pathology in the eye itself. So ask about eye pain. Was it sudden and severe? Is it unilateral, bilateral? And then look yourself for conjunctival injection, fixed mid-iris pupil. Really unlikely to have acute ankle closure glaucoma in PACES, but it could be one of your differentials, just to show them that you're not just thinking of intracranial causes. And finally, I guess just asking them if what medication they currently use for the headaches, and how long they've been on them, because maybe it could be a medication overuse headache. So an approach to breathlessness, again, questions which will get you there are, is it worse in the morning? Then we're thinking this could be obstructive sleep apnea. Is it worse at night? Or are they diurnal changes? Then it's asthma. Is it associated with chest pain or not? Then you're thinking, okay, I need to exclude a PE, or could this be a pneumonia? Is there associated weakness? So if they say yes, where's the weakness and has this weakness progressed? Is it ascending or descending? So could this be GBS? Have they had recent trauma, recent travel, constitutional symptoms? And also don't forget to ask about the social history. So what do they do for work? Do they have allergies? Do they have pets? Just looking for risk factors for shortness of breath and asthma. So how I'd approach breathlessness is just looking at whether you think it's coming from the heart, so could be CCF, arrhythmia, pericarditis, tamponade. Again, in PACES, is tamponade going to come up? More unlikely. It's a medical exam. Respiratory, so pneumothorax, something you'd want to mention, but again, I don't think the diagnosis would be. I mean, it could be pneumothorax, spontaneous pneumothorax in someone who maybe the patient has Marfan's and looks very tall, wide wingspan, and they're coming in with chest pain and shortness of breath. You need to think about pneumothoraces. Then we've spoken about PE, COPD, asthma, ILD, bronchiectasis, lung cancer. Don't forget about endocrine causes like DKA, infections, so pneumonia, PCP or PJP, TB, or even local things like zoster, and ask whether or not they have a rash. And then neurological causes, so GBS if it's ascending up to involve respiratory muscles, myasthenia. Again, the hallmark with myasthenia is the weakness gets worse at the end of the day. And then always remembering in terms of hematological causes, anemia. So have they had recent blood loss? Or maybe they're female and having menorrhagia. So an approach to acute back pain. So looking at the onset again, is it acute, subacute? Where's the pain located? Does it radiate anywhere else? What's the nature of the pain? Is it sharp and shooting? Is it local and burning? What are the alleviating or exacerbating factors? And really important question in anyone with back pain is there any bowel or bladder involvement? Have there been any episodes of incontinence? Any constitutional symptoms? Any trauma or previous fractures? And also start thinking about risk factors for osteoporosis. So do they have a good diet? Are they on long-term steroids?
Are they postmenopausal on HRT or maybe not on HRT? Think about their occupation. Do they do heavy lifting and bending? Social history, do they smoke? And then just remembering red flags. So night pain, you always need to rule out cancer and constitutional symptoms. So looking at causes depending on age. So an 18 to 30-year-old might have trauma, prolapse, ankylosing spondylitis. So for the purposes of PACES, the diagnosis might be ankylosing spondylitis. Back pain in a young person less than 30, is this spond or is it some type of spondyloarthropathy? 30-year-old to a 50-year-old, is this degeneration? Is this early osteoporosis, prolapse, or malignancy? And then someone above the age of 50, again, degeneration, osteoporosis. Could this be Paget's disease? Which I guess could be an easy station 5 case, which might catch you off guard. So just have a read about Paget's disease. And then malignancy and myeloma, key things to remember with back pain and someone over 50 years old. In terms of examination, you then perform with anyone with acute back pain, a focused neurological exam. So do pronated drift, test power in the lower limbs, upper limbs, reflexes, Babinski sign, just a, quick neurological exam. Look at the straight leg raise. So when they lie supine on the bed, they tend to lift their leg and resist you. And if they have, so a true positive straight leg raise test would be if there's radicular pain below the knee, when the hip is flexed so it's basically flexed at 30 and 60 degrees from the horizontal position. And a positive straight leg raise will just be indicating that it could be lumbar disc herniation at the L4 to S1 nerve roots. Again, you will offer a digital rectal exam, and then you might want to mention specific tests. So for ankylosing spondylitis, you might want to mention Schober's test and just have a look up on how to do it. But again, unlikely that they would ask you to do it. So we've gone through all of this really. So just a general approach to weakness. When someone comes in and they say they're weak in a station 5 case, you need to look at what the pattern of weakness is. Is it generalized weakness? Is it weakness of the hands, legs? Which side is it on? Have they noticed facial weakness? Is it distal or proximal? And that's how you will then narrow down, whether you're looking at a proximal myopathy, or are you looking at GBS that's ascending rapidly? Is this a stroke? Is this a TIA? So these are all the key questions to ask in the first couple of minutes. And then the onset was also really important. So is it sudden, chronic? Was it insidious? Was the weakness worse in the morning? Or is it worse in the evening? So if it's always worse in the evening, you might want to think of myasthenia as a cause. If it's generalized weakness, worse in the evening, and maybe sometimes there's some ocular involvement. Spread is a really important question. So has this weakness progressed at all? Or has it just stayed in their left arm? Is there any associated pain? And then on examination, looking for upper or lower motor neuron signs. So this is just something I've taken from a website called Hematology Made Simple, and they have quite a few tips for PACES, etc. So looking at whether it's upper motor neuron or lower motor neuron, is it unilateral? So could it be a stroke or hemisection of the cord, or a unilateral space-occupying lesion, or brain abscess? Or is it bilateral and pure motor? Think of your hereditary causes like hereditary spastic paraparesis. Parasagittal tumor, less likely, but it's something you could mention in your differentials. Bilateral and mixed, so mixed motor and sensory. Could this be subacute combined degeneration of the spinal cord?
if it's a young patient, always ask about if it's a young patient and you're having dorsal column signs with sensory signs and some weakness, always ask about nitrous oxide use or inhaling whippets or anything like that. Table paresis, so this is with syphilis, anterior cord syndrome, and I guess the ones that are important are multiple sclerosis, Friedreich's ataxia. And then lower motor neuron, again, looking at is it pure motor or is it motor and sensory? So important things for a bilateral proximal weakness. Are they on statins? Do they have Cushing's disease? Do they have hypothyroidism? So it's all the endocrine causes here. And then is it lower motor neuron, pure motor with it being bilateral and distal? Then you need to think of myotonic dystrophy. Yeah, and then asymmetric, less likely to get in PACES, but mononeuritis multiplex, multifocal motor neuropathy, and then mixed, all the causes of mixed, which we will go through in a little bit. I see we're almost at 3 p.m. I'm going to run another session on the 7th of October, but I can carry on if just, I think I have one more slide and actually the break, and then we could just carry on the 7th, if everyone's fine with that. So this is what I was talking about earlier. So connective tissue disease screen in anyone with joint pain or mouth ulcers or anything that makes you think this could be an underlying connective tissue disease problem. So you can ask about general fatigue, loss of weight, rashes, losing hair, mouth ulcers, dry eyes, dry mouth, joint pain, difficulty swallowing, heartburn, muscle weakness, muscle pain, diarrhea. Yeah. So this is where I was going to do the break. On the 7th, I think I will carry on with neurology, myotonic dystrophy, Parkinson's, just having a look at all the plastic paraparesis. And then cardiovascular examinations. Yep. Any questions? Okay. So I will put it on YouTube. I think Dr. Addy is asking if there'll be a recording. So it was recorded and it will go onto our YouTube, but I do need to do, it might take like 1 or 2 weeks for me to put it up. Any other questions about PACES? This is the feedback link. I'd be very grateful if you guys can fill it in. Sorry, this is the feedback link. Actually, I think we said we were going to end at 3:30. Who wants to continue for a little bit? I'm happy to go through a few more things. Okay, so I'll just try and choose, high yield things. Let's go to okay, you can go to the neurological exam. Okay, neurological examination, the edge of the bed assessment is key here. Look under the bed, you might find some foot orthoses. You might find splints, which are all commonly missed. And foot orthoses might tell you that, they have Charcot-Marie tooth disease or some type of nerve palsy. So peroneal nerve palsy, less likely. It's more going to be like CMT. So for the neurological examination, so again, introduce yourself, ask for permission. Inspection is really important. I always like to start with some screening tests. So just put that camera on, just show you. So pronated drift. Pronated drift, putting the arms out, ask them to close their eyes and looking for which side, if one side is dropping. Grip myotonia. So you can ask them to grip something. And if they have myotonic dystrophy, you'll see that they struggle to relax after they've gripped something. Rebound phenomenon is in with cerebellar pathology. So normally if you have someone's hand in space and you tell them to keep their hand in space here and you push down, so I can't really do it to myself. So I push my arm down, you'll see there's a rebound and my arm comes back up. But when the cerebellum is damaged, that rebound is lost. So the arm carries on to drift down and you don't get the rebound. Tapping fingers, so that's a quick screen for Parkinson's disease. So you ask them to do this. And you see with Parkinson's disease, the movements, instead of staying like this, they get from bigger, they get smaller and smaller until they almost stop. And then moving on to motor. So assessing tone, power, reflexes, sensory exam. So power, sensory exam, soft touch, pinprick. So they'll literally have some cotton wool in the exam. They'll also have some little like lancet devices. Remember not to put too much pressure. It's a light prick. You don't want to be causing any petechiae on the patient. If you are running out of time and you have to choose between soft touch and pinprick, I'd say a better discriminator is pinprick. I ran out of time in my exam, I think. I think I didn't get to, I was doing vibration, but there was a level or something. And yeah, but it was all fine. I still passed. I think they subtract like 1 mark overall for not finishing. I think I hadn't finished vibration sense, and that was the last thing. But really, if you're running out of time, just try and decide which of the two you do. And I think pinprick would probably be better. Joint position sense. So just practice this a lot. The more you practice, the better you'll get at it. And practice how you're going to explain to the patient. You need really clear instructions. Same with vibration sense. And then quick cerebellar screening signs. So if you are assessing upper limbs, finger nose, or alternating hand clapping, looking for nystagmus. So the neuro exam, generally, they'll either ask you to do an upper limb exam. So they might say, this is a gentleman with weakness of his hand, please examine the upper limbs. Or this is someone with weakness of his leg, examine the lower limbs. Or they might ask you to do a cranial nerve exam. I think in the past, many years ago, they used to just have more open questions saying, examine the neurological system. But I think that was quite challenging in terms of knowing without a proper history what to examine. So now they'll be quite clear and say, please examine the upper limbs, please examine the lower limbs, or please examine the cranial nerves. And then just remember with your upper limbs or lower limb examination, you need to do motor, sensory, a cerebellar screen, and gait, and the gait assessment. Some people like to say that starting with gait is the best because then you can get the diagnosis. I started with gait in my exam and I think it wasted all my time. So I'm not so sure if I would carry on recommending that. I think when you're speaking to them, the key thing is to look for foot orthoses, because if you see those, you're thinking, okay, this is going to be hereditary sensory motor neuropathy, so Charcot-Marie-Tooth, or some type of nerve damage. Also look for other clues like, do they have pricks on the fingers? Is this diabetes? Yeah. So this is just looking at group myotonia. So in myotonic dystrophy, the more you ask them to grip something, you'll see that the muscles actually start contracting and they find it very difficult to relax after repeatedly gripping something. I'm sure you guys all know this. You could take a screenshot. It's just quick cranial nerve examination. If you were asked to do the cranial nerves, you can ask if you've noticed any change in your sense of smell. Do a quick visual acuity assessment. I'd say never do the corneal reflex. Look at accommodation, visual fields. Yeah, but don't focus too much on this. Move straight on to the 3, 4, and 6, and then yeah. If also another tip is if you think there's pathology with, let's say, the 6th cranial nerve, always examine the nerves around it. So say you think, could this be vestibular schwannoma or something in the auditory canal? Then you'd want to examine with cranial nerve 6 pathology, examine cranial nerves 5 and the one above thoroughly. But in a 6-minute exam, I think what I was doing, I was able to ask when I was practicing, have you noticed a change in your smell? I was doing a quick Selden's chart, so I wouldn't do the whole chart. I would just go to the last line and say, can you read the last line? And if they couldn't, go to the one above that. Visual fields, so quickly cover your eye and do the quadrants. Reflexes I wouldn't do, but I would do light, so swinging flashlight and accommodation. And you can mention fundoscopy, but in a cranial nerve exam, they will tell you not to perform fundoscopy. I'm quite sure of that. But also just know how to do fundoscopy in general, because it is something that comes up really often. And then 3, 4, and 6, so quick H sign, look for nystagmus, then trigeminal nerve, just sensory, motor. So ask him to bite down, feeling over the muscles. Again, don't do the corneal reflex and don't do the jaw jerk. It can be, you could mention I would do the corneal reflex and jaw jerk. Ideally, I would do them, but it can be quite scary for the patient seeing you tapping something on their jaw. Then 7th nerve, so just look for symmetry. You don't need to ask about taste. When I practiced, I just did symmetry, muscles of facial expression, so raising your eyebrows, blowing out your cheeks, or showing me your teeth. And then for the 8th nerve, what I would do is I just do a whisper test. So cover one ear and whisper a number and see if they can hear it. And if they have a tuning fork at the bedside, you could offer to do Weaver's and a Rennie's test. Then moving on, cranial nerve 9 and 10. So just look at the uvula, see if it deviates. You can listen from the speech to see if there's any dysarthria or dysphonia for the vagus nerve, and then hypoglossal nerve, so 12, stick out the tongue, look for any deviation, just remembering that if you have a cranial nerve 12 lesion, so hypoglossal lesion, the tongue deviates towards the side of the lesion because that strong side is pushing the tongue over onto the weak side. The muscles on the strong side are pushing over. Whereas if you have a cranial nerve 9 lesion, the uvula will swing away from the side of the lesion. And then finally, accessory nerve. So looking at the shoulder muscles, shrugging shoulders, turning the head against resisted head turning. So these are a few possible cases: Parkinson's disease, peripheral neuropathy, CMT, MS, spastic paraparesis, cerebellar degeneration, and myotonic dystrophy. Just for Parkinson's disease, it's important to look for the resting tremor. And sometimes you can ask them to tap on their leg and distract them to assess whether the tremor is more pronounced thereafter. Look for rigidity, hypomimia, drooling, change in speech. The motor exam, look for cogwheeling. And something that really brings out the cogwheeling is if you ask them to tap with the opposite hand on the leg, you'll really be able to appreciate the cogwheeling. And then autonomic symptoms, you won't be able to really assess that, from your examination, but it's something you could mention to the examiner at the end, is that you'd be concerned if there were autonomic symptoms to exclude Parkinson's disease, as well as the differentials for Parkinsonism, so Parkinson's plus. It's going to come on the next slide. So in terms of gait, look for fascination on turning, which is just, you see that they're very hesitant when they're going to make a turn after walking. Might have a wide-based gait. And in terms of writing, someone with Parkinson's disease has very small, if you ask them to draw a spiral, they'll draw really small versus essential tremor, which is so big, but is larger. There's an actual description for this, I've just forgotten it. Let me just see. Oh yeah. This is the reduced diameter of the spiral drawing in Parkinson's disease, and then very tremulous in essential tremor. So differentials for Parkinsonism. So always think of idiopathic Parkinson's disease, Parkinson's plus syndrome. So progressive supranuclear palsy if they have visual symptoms, and then cortical basilar degeneration or syndrome, and multi-system atrophy. I think when you have a case of Parkinson's disease, always mention that to complete your examination, you'd want to do a lying and standing blood pressure. You'd want to assess for other autonomic features, because it will show that you're also thinking not just about idiopathic Parkinson's disease, but about Parkinson's plus and specifically multi-system atrophy, which has a lot of autonomic features. So peripheral neuropathy, know this really well. So know all the causes of peripheral neuropathy. Also try and look up which causes are mainly motor or mainly sensory. So you have metabolic causes, drug causes, paraneoplastic, inflammatory, infectious, and hereditary. Differentials for a sensory motor peripheral neuropathy would be all of these. So I guess the commonest ones to mention when you have a sensory motor peripheral neuropathy is diabetes, and look for the finger pricks, alcohol use. But again, you might find that, do they have any cerebellar signs with this chronic alcohol use? Any of the organ failures also, and a few of other causes. So Charcot-Marie tooth, so this is a really well patient who can come in from anywhere really. The clues are splints at the bedside, they have pes cavus, so the high arching of the foot, they have distal muscle wasting. It's generally a mixed motor and sensory polyneuropathy, and it's mainly peripheral. Their gait is quite high stepping and very classic. Also, just remember that differentials for pes cavus could be Friedreich's ataxia if they're also cerebellar signs, polio, and remember that although polio is a thing of the past, there's still something called post-polio syndrome, which is important to read up on. So it's basically when someone has polio, they could have chronic fatigue symptoms and chronic pain called post-polio syndrome. Less likely to come up in your exam, but I do know that there are some centers which are post-polio centers of excellence. So maybe have a look and see, what types of wherever your PACES exam is, just have a look at what services that hospital offers. So if they have a renal center, you're almost guaranteed to have a renal case. And if they have a post-polio syndrome, it's a very easy patient they can bring in. And then syringomyelia or cerebral palsy, but less likely to get cerebral palsy in the exam. So multiple sclerosis, always think about this as a differential in any young patient, especially if they're female. They're going to have general symptoms of fatigue and weakness. They'll have upper motor neuron features, and they'll have features that don't really fit together for a specific type of, you'd have difficulty localizing it to the spinal cord or to the brain. This is when think of multiple sclerosis, when the sensory findings, diplopia, weakness, and cerebellar signs. The R is just missing there. Spastic paraparesis, so are they in a wheelchair? Do they have increased tone, clonus, hyperreflexia, weakness, and wasting with no fasciculations? Because the fasciculations are a hallmark of low motor neuron pathology. Is there a sensory level? Look for scars over the back, really important. This might be your only finding. No, not your only finding, but it might be your clue to whether they've had a previous slip disc or an epidural tumor and required some type of surgical intervention. And you can put it all together really nicely, saying, I think this is spastic paraparesis, and I believe there was previous surgery at the T4 level, evidenced by the scar on the spine. And then again, for spastic paraparesis, if there are cerebellar signs, think of Friedreich's ataxia. If they're ocular signs, consider multiple sclerosis. So just a few differentials for spastic paraparesis. And remember that with motor neuron disease, you get mixed upper motor neuron and low motor neuron signs. So differentials for spastic paraparesis with a sensory level. If you have a spastic paraparesis and a clear sensory level, it's either going to be cord compression due to various reasons, a cord infarct, or transverse myelitis. If you have spastic paraparesis and dorsal column loss, then you might have think of something, a demyelinating process like MS. Think of Friedreich's ataxia, subacute combined degeneration of the cord due to B12 deficiency, especially if they're using recreational nitrous oxide, syphilis, a parasitical meningioma, or cervical myelopathy. Again, cervical myelopathy, the spastic paraparesis would be happening higher up, so from the cervical level. Spastic paraparesis and spinal thalamic loss, think of syringomyelia or an anterior spinal artery infarct. And then spastic paraparesis and cerebellar signs, so always think of MS, Friedreich's ataxia, spinocerebellar ataxia, and Arnold-Chiari malformation or syringomyelia. If you have absent ankle jerks and upgoing planters, you could mention in your differential that it could be subacute combined degeneration of the spinal cord, Tabes dorsalis, which is in syphilis, Friedreich's ataxia, or very rarely dual pathology. So if there's peripheral neuropathy and spastic paraparesis. But I think I would leave number 4 out and go with the more common things first. So cerebellar degeneration. These are the signs. I think have a better. Yeah, so these are the signs. You just use the mnemonic Danish. So dysstaticokinesia, ataxia, nystagmus, intention tremor, slurred staccato speech, hypotonia, and heel-to-shin test. Differentials for cerebellar signs. So you can use the mnemonic pastries. So paraneoplastic causes, alcohol, MS or stroke, tumor, rarer causes like multi-system atrophy, which is a Parkinson's plus syndrome. So in that you'll have cerebellar signs. You will also have autonomic features like postural hypotension, and you'll also have features of Parkinsonism. Then Friedreich's ataxia or atelalgic telangiectasia. Ataxia, telangiectasia. Iatrogenic causes, so are they on any drugs such as phenytoin? Are they hypothyroid, or have they had a stroke? And then always think about if they're having unilateral cerebellar signs, is this a unilateral space occupying lesion? Is it a stroke? Is it MS, or has there been trauma? If it's bilateral, think of systemic things like drugs, alcohol, Friedreich's ataxia, or all the other systemic causes. Myotonic dystrophy. So this is really a spot diagnosis. I had in my mock PACES exam. It was the first time I'd seen myotonic dystrophy in person. So this was basically just my PACES course mock test. And my patient had a classic pacemaker scar, infraclavicular scar, frontal balding, ptosis of both eyelids. So these are things you need to look out for. Slurred nasal speech, cataracts. So you can see the cataract. So if you're looking in the eye, you get that, that basically a reflection, and then they've had a cataract. Cataract, an intraocular lens for likely a cataract. If you get the reflection when you look onto the eyes, very distinct sign for an intraocular lens. Screening, so percussion myotonia, that's just if you tap on the muscle, you might see that the muscle starts to contract and takes a long time to relax, or the hand grip myotonia, which we went through. Motor exam, they have reduced power in the facial and bulbar muscles, distal weakness and absent reflexes, and then finally the other systems. Look at the cardiovascular system for a pacemaker, think about cardiomyopathy, and think about asking about hypogonadism. And I guess other tips would be just not to forget to brush up on motor neuron disease, myasthenia gravis, proximal myopathy, and then nerve palsies. And this is a quick way of assessing whether it's ulnar, radial, or median nerve palsy. And I think we'll stop there. So I'll just put the feedback link back in the chat. Let me know if you have any questions. So Dr. Addy asked, if you suspect cancer, but the patient has non-specific symptoms, would you suggesting the novel Galleri blood test? I think I would have mentioned this in an exam setting. I'm not sure how the examiners would take to it. Just mention common things. The next session will be on the 7th of October, and it's the same link that you guys used to sign up for this session. So 7th of October, I think it will be 1 to 3:30. Yes, we're done now. Dinesh is just asking. Yes, you can leave. I'm just waiting to see if there are any other questions. Thanks for joining.